Chapter 43, the care of patients with integumentary disorders and burns. Many skin diseases result from infection with bacteria, viruses, or fungi, or from an infestation with a parasite. Skin diseases require special precautions to prevent the spread of the infectious organism or the parasite. Hand hygiene is a first-line measure in the prevention of healthcare-associated infections, and it is mandated as one of the Joint Commission's national patient safety goals. Skin disorders that need contact precautions are Group A streptococcus, herpes, simplex disseminated herpes zoster, impetigo, infection or colonization by a multi-drug resistant bacteria, pediculosis, scabies, a skin wound or a burn infection, contact dermatitis, atopic dermatitis, stasis dermatitis. Dermatitis is diagnosed by inspection and by compiling a complete history looking for any possible exposure to a causative agent. The nurse will teach the patient to avoid contact irritants and to properly care for their skin, instructing them in the proper way to apply topical agents. Acne rosacea usually begin between the ages of 30 to 50 years old. It is characterized by erythema, papules, pustules, and telangiectasias, which is dilation of capillaries that cause small red or purple clusters. It will occur on the face, over the cheeks, and the bridge of the nose. Acne vulgaris is more common than acne rosacea. Factors that contribute to the development of acne include heredity, increased androgen levels, and premenstrual hormone fluctuations. Non-prescription medications like lotions, creams, and gels that contain sulfur benzoyl peroxide or sulfur combined with resveratrol usually are effective for non-inflammatory acne. The disease is unpredictable and it tends to go into remission spontaneously and sometimes will clear up temporarily with or without treatment. It may also affect the scalp and can be confused with seborrheic dermatitis. Patients will need instruction about the nature of the disease, teaching about the purpose of the prescribed treatment, and information about aggravating the disease. The skin needs to be kept moist and pliable. The treatment of Stevens-Johnson syndrome involves discontinuing the drug and providing supportive care with fluids and nutrition. Wound care is similar to burn care. The lesions are painful and analgesia is provided. Sedatives may be necessary. If it is not treated early, Stevens-Johnson syndrome may cause death. Nursing interventions are aimed at healing the infected area and preventing reoccurrence. The patient is taught to avoid using cosmetic products and over-the-counter topical remedies on affected areas. This image is of herpes simplex virus lesions. Auto-inoculation of the virus is possible by direct contact, lips to fingers, to genitals, or lips to fingers to the eyes. Patients need to be cautioned about using good personal hygiene to prevent the spreading of the virus to the eyes, genital area, and other body parts. Hand hygiene is simple, but it is essential in preventing the spread of a virus. Herpes varicella zoster causes chickenpox in young children and shingles in all ages. In herpes zoster, the herpes viruses replicate in the peripheral nerve ganglia, where they lie dormant until reactivated by trauma, malignancy, stress, or local radiation. The earlier the condition is diagnosed and treated, the better chances to decrease the amount and duration of the associated pain. The varicella vaccine is given in 2 doses to children to prevent chickenpox between the ages of 12 to 18 months for the first dose, and the second is at ages 4 to 6 years. Herpes zoster begins with vague symptoms of fatigue, a low-grade fever, possibly a loss of appetite. There may only be aching or discomfort along the nerve pathway with or without erythema. 3 to 5 days after the onset, small groups of vesicles will appear on the skin, usually found on the trunk and spread halfway around the body, following the nerve pathways leading from the spinal nerve to the skin. The care includes symptomatic relief from the pain and the itching, as well as the prevention of a secondary bacterial infection. Fungal infections are called mycoses. Systematic fungal infections involving the lungs and other internal organs are called systemic mycoses. 2 groups of fungi cause infections in humans. 1 are fungi that are truly pathogenic to humans, and 2 are fungi that are opportunistic infections these are cause an infection when the host has an altered immune system. Most types of fungal infections involve skin are tinea pedis, which is athlete's foot, tinea cruris, which is jock itch, and tinea capitis, which is ringworm, tinea barbae, which is barber's itch. Thrush, which is a fungal infection, can attack mucous membranes of the mouth, rectum, and vagina. Onychomycosis is nail fungus. Hands and feet need to be thoroughly dried after becoming wet, drying between the toes after bath or shower. Nails need to be cut straight across without rounding the edges. The infection may spread to the entire foot and cause blistering, peeling, cracking, and itching. Tinea pedis is contracted and spread in swimming pools, spas, and showers. Lice eggs, known as nits, are deposited at the base of hair shafts and can be seen on close inspection. Scabies causes curved or linear white or erythematous ridges in the skin that are easily visible. Drugs most commonly used and considered effective against lice and scabies are permethrin, pyrethrins, and malathion. Some of these are available over the counter. More than 5 million cases a year of basal cell and squamous cell cancers occur within the United States. Basal cell carcinoma appears as small, scaly areas and tends to become larger as the disease progresses. Squamous cell carcinoma is caused by sunlight, affects the epidermis, and can become invasive and metastasize to other areas of the body. Malignant melanoma is the least common form of skin cancer, but it causes most skin cancer deaths. It arises from the pigment-producing cells, varies in course and prognosis according to its type. Malignant melanoma always requires surgical removal of the tumor and the excision of adjacent tissues and possibly nearby lymphatic structures. Chemotherapy may be used to destroy tumor cells believed to have migrated beyond the tumor site. Removal of cancerous skin tissue will depend on the type of malignant growth present. In all but the most extensive growths, treatment is relatively simple and completely successful if started early. The top image is basal cell cancer, and the bottom image is squamous cell cancer. When a patient is on bed rest or constantly sitting because of paralysis, pressure against the skin in various areas interferes with circulation. Cells can die very quickly without adequate blood supply. Depending on the patient's general condition, weight, and other factors, skin damage may occur within a few hours to a few days. Areas most prone to pressure injury are those over bony prominences. The National Pressure Ulcer Advisory Panel has updated pressure ulcer definitions for the prediction and prevention of pressure ulcers and a staging system for classification. Suspected deep tissue injury, intact skin with a purple or maroon discoloration. Tissues may be firm, boggy, painful, cool, or warm. A stage 1 injury is an area of intact skin that is reddened, deep pink, or mottled that does not blanch. A stage 2 injury is partial thickness skin loss involving the epidermis or dermis or both. The skin appears blistered or abraded and has a shallow crater. The area surrounding the damaged skin is reddened and will probably feel hot or warmer than normal. A stage 3 injury, the skin is ulcerated. There is a crater-like ulcer, and the underlying subcutaneous tissue is involved in the destructive process. The ulcer may or may not be infected. Bacterial infection is almost always present at this stage and can account for continued erosion of the ulcer and the production of drainage. A stage 4 ulcer, there are deep ulceration and necrosis that involve deeper underlying muscle and possibly bone tissue. The ulcer can be black, dry, and covered with a tough accumulation of necrotic tissue, or it may be made up of wet and oozing dead cells and purulent exudates. An unstageable pressure injury is a full thickness wound that has eschar, tissue, or both that obscures the depth determination. Debridement may be done surgically with forceps and scissors or mechanically. Mechanical debridement is accomplished by whirlpool baths, wet to dry dressing, dextrometer beads sprinkled over the wound, or chemical products that can break down dead tissue and absorb the exudate. Wet to dry dressings are not recommended because of the damage that occurs to new granulation tissue when removed. After sharp debridement with bleeding, clean dressings are used for 8 to 24 hours, then moisture-retaining dressings are applied. Pressure ulcers need to be measured and documented when discovered and once a week thereafter. Document the characteristics of the wound and the exudate that is present. Exudate is purulent, serous sanguineous, or sanguineous. Purulent is pus, serous sanguineous is serum and blood mixed together, and sanguineous is serum. The pressure ulcer scale for healing, or the push tool, is an objective document of findings. Photographs taken of the ulcer on discovery and during treatments to assist to document the progress. 486,000 Americans seek a cure for burns each year. Most burns are relatively minor, but approximately 34,000 patients are hospitalized for burns. Fire and burns kill nearly 4,000 people yearly in the United States. Today, fluid resuscitation, burn wound excision, grafting techniques, new skin coverings, and nutritional supplementation has ensured that a patient may survive a 99% or 99-degree burn. The Lund-Browder classification or Birchow chart can be used to compute the depth of the burn and the extent of the injury according to age and total burn estimate. This is used as the basis for treatment. The tissues involved in burns are of various depths. A first-degree burn is epidermal tissue. This is super epidermal layer and it does not need treatment. These are routinely blistered or reddened. Superficial partial thickness wounds are second degree. The epidermal appendages, the sweat, oil glands, and hair follicles are not destroyed, and the wound will heal if no further injury occurs from infection or inappropriate treatment. The deep partial thickness wounds, which are second degree, include tissue through the lower layer of the dermis and will require surgical treatment. Full thickness wounds are third degree burns. These involve all layers of the skin and the destruction of epidermal appendages. This will require grafting for the wound to heal and for optimal functioning to be restored. Fourth degree burns involve underlying structures, which is muscle, fat, or bone. All burn patients are treated as trauma patients. It is vital for the establishment and the maintenance of a patient airway. This is the #1 priority. For minor burns, cool running water should be applied continuously for the first 10 to 15 minutes. There should be a dressing applied loosely with a sterile gauze bandage. The nurse needs to watch for increasing restlessness, coughing, hoarseness, rapid shallow respirations, stridor, and falling oxygenation saturation. A major concern in the care of a burn victim is to prevent shock from circulatory collapse. The two most important measures used to relieve profound shock are replacement of lost fluids and electrolytes, which is fluid resuscitation, and the enhancement of tissue perfusion. In trauma patients, a Foley catheter is inserted to monitor hourly urine output and provide data to determine whether fluid resuscitation is adequate. The minimal acceptable urine flow for an adult per hour is 30 milliliters. An eschariotomy is where eschar is a source of infection and it impairs healing. The removal of the eschar and necrotic skin or the debridement is done within 24 to 72 hours after the burn. With grafting, the patient's own skin is the only permanent graft material that may be used. IV lines are established and fluid resuscitation is begun. Then pain control begins. Measures to relieve pain include administration of IV morphine or hydromorphone hydrochloride, which is dilaudid. Doses of IV morphine higher than accustomed to seeing, which would be 2 to 4 milligrams every 5 to 10 minutes, may require a much larger dose if the individual is in severe pain. The granulation stage of repair, the wound should appear slightly pink and somewhat shiny. Healthy granulation tissue does not emit exudates. Very wet wounds with foul odor indicate infection. A greenish-blue wound exudate is a sign of Pseudomonas infection. Signs of inflammation, redness and swelling of the tissues that are adjacent to the wound may indicate cellulitis. Nurses need to assist patients when it comes to pain control with the patient that has burns.